Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing US healthcare system. Well, I'm back. I have not made a video for you guys in a little while. I apologize for that, but I've had a pretty good excuse. I have been moving my family internationally. We've just finally sort of gotten settled in here, our new home, which is Abu Dhabi, United Arab Emirates. So quite a distance and quite a difference from Central Oregon, where I've been broadcasting to you guys since the beginning of this channel. So I'll probably go into why we made this move at a later point. There's a few other things I want to talk about in this video that are more related to our typical men's health topics. But I do want to do a little bit of housekeeping and just kind of talk a little bit about the future of the channel now that I've made this move. So as many of you know, I'm still a full-time practicing emergency medicine physician. So I've taken a position out here at a extremely busy urban hospital, many beds, level one trauma center, and I'm a busy guy. I'm a busy guy. So we see a lot of patients. There's a lot of pathology through here that comes through here. So I fully intend on keeping this channel active. I will do my best to keep putting out regular content for you guys. Just understand there may be some delays between videos every now and then, just because the amount of workload that I've taken on as a result of this new position. So I'm not only working full time in the department, but now I have a residency program that I'm affiliated with as well, and I'll be teaching residents. On top of that, my second son is about to be born here in the next month, so we're gonna have a new baby in the house. So um, yeah, it's still not sure how I'm going to juggle all this, but anyway, I'm going to make it happen for you guys. More housekeeping stuff. The private practice. Those of you guys who are my patients, know all about this. It's obviously still going to be active. It's a telemedicine-based practice, so it can be done from anywhere in the world. However, my practice has kind of reached its capacity at this point. I have openings for perhaps two empty slots that I can take new patients in. So if you're interested in joining the practice, you can certainly book a consultation with me. I have free 15-minute openings available where we can kind of talk about it, see if we're a good fit for each other. But the practice will stay open. I'm just going to have to, unfortunately, not accept new patients because I'm pretty much at capacity at this point. And I certainly will, if you want to give me your information, I can keep you on a waiting list as necessary. Now, maybe as time goes on and things settle down a little bit, and certainly into the future, this practice is going to grow quite a bit. But as it stands right now, I'm not really willing to compromise on the quality and the amount of time that I'm able to dedicate to my patients just to stuff more guys into the practice and give you subpar care. So the practice will still remain, but it's about to be capped. So if you're interested, this is your final chance, at least for a long time. Shoot me an email. We can set up a time to talk about it. So anyway, let's move on to what we wanted to talk about today, which is a little bit about DHT. This whole week, I was kind of struggling about what I'll do for my next video, and I was inspired to do this by a video that came out on the TRT and hormone optimization channel, Stephen Devos's channel. In my opinion, the best men's health and just general TRT and hormone channel on YouTube. Pretty much everybody that comes onto that channel is extremely knowledgeable. You'll learn a lot, so I recommend checking out that channel. But they recently had two guys that I respect a great deal, Dave Lee and Kyle Gillette, get on and talk about 5-alpha reductase inhibitors and the hormone DHT, dihydrotestosterone. Now, Dave is generally averse to the use of these medications, as am I. Kyle's a bit more liberal with them, but he justifies his stance, I think, quite well in this video. So I'll put a link to it. I encourage you guys. You may actually want to just stop right now and go watch it if you haven't already, because you might get more out of the video that I'm about to make here if you already have the background, if you've watched this video and you have an appreciation for the arguments on both sides. I'm not going to be able to like comprehensively go into DHT, although I think I will like to do something like that for you guys, maybe in a series of videos. But what I want to do is highlight a few of the comments that were made in the video that I think were quite good. There were some that were just sort of briefly mention some ideas related to DHT and 5-alpha reductase inhibitors that I wish they had more time to go into and delve into. There were some things I think that were stated as fact that are really maybe not so solidly factual, or at least based on the prevailing evidence. There's certainly some leeway, and I have some skepticism about a few of the claims that were made, or comments, I should say. So I want to present some of the evidence regarding those, just so you guys have a better understanding of these drugs and of dihydrotestosterone in general, and why it's actually a really, really important hormone. So there were a number of things about this video that I really, really appreciated. One, obviously, for some reason, this is a contentious thing, just like estradiol. So it's nice to see like two well-educated professionals just having a nice, cordial, professional discussion, and not, arguing with each other or being unprofessional. I think you can tell that they're friends. They did a good job, each stating their case quite well. And I felt like most people will get a lot out of this video. I appreciate the fact that both of them, obviously, even Kyle, who is again more pro 5-alpha reductase inhibitor, you can tell I think he appreciates the risk, that these are not risk-free drugs. Both of them went out of their way to state that, and they're not for everybody. And best of all, I like that they said, listen, these drugs should not be prescribed just willy-nilly. They should be prescribed only once you have sort of a shared decision-making process with the patient. So that you have to sit down with the patient, just like with all drugs and interventions, and have a frank discussion about the risks, the benefits, the alternatives. And then ultimately it's up to the patient, to make that decision whether they want to move forward with this medication or that medication, or whatever intervention you're talking about. So that's not just something for finasteride or testosterone. That's just good medicine, right? You just want to sit down and you want to have a well-informed patient who understands what they're getting into. And so that if there are adverse effects down the road, they're not unexpected. And the patient can't say, hey, you never told me that, X, Y, or Z was going to happen. So I like that they both said that. It's great. Anyway, great video. I think you guys should go and check it out. I guess we should first start out with my own personal bias about this. There's a trend in the TRT world that seems to suggest that you need to have, when you start on testosterone, you don't just need testosterone. You need to start adding in all of these adjuncts. And you see it all the time on the forums, and there's no shortage of these windmill sort of clown clinics, as I call them, that are more than happy to provide all these ancillary medications that they tell you need, when in fact, in a properly structured TRT protocol, you don't need any of them. TRT, when done properly, structured properly for the vast majority of men, in and of itself is sufficient. And these additional medications, in my opinion, are rarely necessary. There's always outliers, of course. But in general, if you're on a good protocol and you're doing the lifestyle stuff that you need to be doing, you're eating properly, you're training, you're lowering visceral body fat, you're treating your sleep apnea, you're doing all the other lifestyle things that go with a properly structured hormonal optimization program, you don't need these extra drugs. And this includes aromatase inhibitors. It includes drugs like finasteride and dutasteride. It includes peptides. It includes enclomiphene. All these adjuncts that these clinics are trying to sell you, you don't need, for the most part. Now, there's going to be outliers. There's going to be people on either end of the bell curve. But in general, if you're on a good protocol, you don't need to control estradiol, for example. If you're on a good protocol, you don't necessarily need to control dihydrotestosterone and manipulate it artificially. These downstream metabolites of testosterone, DHT and estradiol, they exist for a reason. They are created for a reason. They're crucially important to almost all bodily systems. And so, you can get away sometimes with manipulating these pharmacologically, but sometimes you can't. And there are people that run into trouble when they do this, and they compromise their health. And when in reality, they never really needed to be on these drugs in the first place. So that's my own personal bias, is that, testosterone is the therapy for the therapy for low testosterone hypogonadism is to replace testosterone. And then you allow the body's natural mechanisms, which produce DHT, which produce estradiol, and of course, all of their downstream metabolites. you let those processes run as nature intended them to, and then you combine that with the proper lifestyle interventions, and that's where you see the biggest changes in people's health. So, in general, these drugs are just not necessary. Again, for the vast majority of people, I'll say it again, there's always going to be the outlier. There's always going to be the one guy, that you can make a case for one or more of these interventions. But the vast majority of guys, you don't need an anastrozole. You don't need finasteride or dutasteride. You don't need clomiphene. You don't need enclomiphene. You don't need all these peptides. And you just need to let the body do what the body does. And you give it the proper substrate, which is testosterone. So that's just how I feel about that. I think that playing around with these can often backfire and lead to more serious problems down the road. And we'll talk just briefly about that. Now, the other thing that they mentioned in this video, and I think it was Kyle that brought this up, but it could have been Dave, I don't remember, that I think may have slipped by some listeners is the case for these drugs, for these 5-alpha reductase inhibitors, were in men who were taking excessive amounts of androgen. So super physiologic amounts of testosterone leading to super physiologic amounts of dihydrotestosterone, which then, caused, a number of downstream issues that we'll talk about here in a second. So I don't know that maybe was emphasized as strongly. It's one thing to be taking TRT doses of testosterone in order to alleviate symptoms of low testosterone, in order to optimize health. And then it's a whole nother thing to be taking bodybuilding doses of not just testosterone, but also adding in synthetic androgens, some of which are DHT derivatives. That physiology is totally different, and that's a completely different ballgame. And maybe in that really warped and skewed hormonal state that we find like professional bodybuilders in, for example, if you're taking 1.5 grams of androgens a week, you very well may need to consider a 5-alpha reductase inhibitor to manage that androgen load and avoid some of the potential side effects. Here's the thing, there's no data, like very, very, very little data in that group of people in terms of what needs to be done to manage that, in terms of aromatase inhibitors and finasteride, et cetera. Like, it's just not studied. So we have animal studies, and this is something you see again, not just in this particular talk, but just to kind of in general in the men's health space, is that we extrapolate information from animal studies of variable quality, or we extrapolate data from a few studies in humans that are quite small and underpowered, and then it's repeated a lot, and then it's sort of taken as a fact and as something that we should apply to everybody. When really we should be caveating a lot of these recommendations with, well, we think that data seems to suggest that. So you have to sound like I do a lot, which is kind of wishy-washy. And, quite frankly, patients don't like that, and I understand, but that's just the state of the science. There's not a lot in terms of these drugs when it comes to men on TRT, and certainly men on high doses of androgens, that we can state definitively at this point. There are studies that suggest X and studies that suggest Y and Z, but we still have to be careful in what we do. And a lot of times we end up doing things that sort of make sense mechanistically or physiologically, but don't have any support in the literature. One of the examples was Kyle mentioned that he will dose, I believe he said it was dutasteride in an intermittent fashion, sort of mimicking, he mentioned bipolar androgen therapy, which is a kind of an up and coming way to address prostate cancer, which does have good literature support. And what he's saying about doing that, it makes physiologic sense. It might actually be perfectly okay. In fact, it might be, if you're going to use these drugs, an ideal way to perhaps derive benefit and minimize side effects. But we have to understand, and there's no offense to him, but he just made that up. As far as I know, he's just made up that protocol. It's not like that comes from a double-blind randomized controlled trial. If I'm wrong, please send it to me because I'd be happy to read it. But he's a smart guy. He looked at the half-life of this drug, he looked at how it works, and he came up with a protocol in terms of how to dose it that seems to make sense. But it hasn't been studied to any degree that I'm aware of. And I looked and looked and I couldn't find anything on it. It may be perfectly okay. I don't have a problem clearly with him doing that or prescribing it. I have no issue whatsoever. But it's something that you have to tell patients that. You have to say, hey, listen, this is a protocol that I've come up with. It's not based on any research study, but here's why it makes sense, and you can lay it out for them. So there's a lot of that in men's health, and it's not necessarily a bad thing. It's just it's just how we have to work in this environment. Like there's never going to be the level of study, certainly that a nerd like me is going to want to have in order to support my practice. A lot of times we have to do things that make sense mechanistically and physiologically, and that we've seen with our own eyes with patient experiences over the years that work, and then and just kind of go from there. So that's just the way it is. Okay, so that's enough of that. Get off my soapbox. I want to actually focus not so much on the cosmetic part of their talk, where obviously these drugs get used for androgenic alopecia, for hair loss, but I don't want to spend too much time on it. I want to tackle some of the other things that were mentioned in the talk and show you guys some data, specifically in three areas. Obviously, the cardiac hypertrophy thing came up. I want to mention that. So left ventricular hypertrophy. Talk briefly then also about hematocrit issues and whether finasteride can be used for that, to manage that issue. And then finally, the psychological parts of it as well. We'll talk just briefly about post-finasteride syndrome, because that's the thing we all worry about, is when you use these drugs, there's a non-zero chance of a potentially serious, devastating, lifelong, in some cases, adverse syndrome, which if you suffer from it, can be absolutely debilitating. So you do roll the dice a little bit. I think Dave used the term Russian roulette when you use these drugs, and I do agree with that. I think that there is a risk, and we don't know exactly what it is, so you really got to know what you're getting into. But that's kind of the areas I want to talk to you guys about. Now, as far as the hair loss part of this goes, I'm sympathetic to this issue, obviously, and I understand if you're, especially a young man in your 20s, you're losing your hair, you're in the dating market. Like, this can be emotionally devastating. It can be massively anxiety provoking, and so in those situations, you may be willing to take the risk of using these drugs because they do work to a certain extent. They certainly will slow the rate of hair loss over the years, but you have to continue taking them. And so every year that you're on these drugs, there is an ongoing risk of an adverse effect of some kind. So you have to weigh that with the thought of your hair thinning and eventually looking like me or Dave. So the other thing I think I want to impart, again, and this is also this is just my own personal bias. The losing your hair as a man, this is a genetic phenomenon. It's polygenetic, I mean there's more than one gene, but clearly DHT is a major component in hair loss. Otherwise, these drugs wouldn't work. Barring some major breakthrough, whether it's in stem cell technology or CRISPR technology, where your DNA is rewritten, if you have the genes for androgenic alopecia, especially if you're one of these unfortunate guys who's losing their hair in your 20s, you do have to come to terms, I think, with the fact that, again, barring some major breakthrough, you're going to lose your hair. It's going to happen either sooner or later. Now, you can use these drugs and others to slow that process. So maybe you can put it off by 10 years. Maybe you can put it off for longer than that. Or we don't really know. I mean, the response is variable. But I think you need to internalize the fact that you're going to lose your hair. And, there are ways, again, there's ways to mitigate that. Some men get hair transplants, which sometimes I've seen some that look really good, and I have seen others that they don't look so good. Or they may look good for the first 5 or 10 years, but then you obviously continue to lose hair, and eventually you're going to run out of donor sites. And so, you end up like Joe Rogan had a hair transplant. And, you know, it just didn't work out for him. So now he's got to shave his head, and he's got this big scar on the back of his head. So there's no great solution to hair loss. Whoever solves that problem will not only be very wealthy, will probably get a Nobel Prize, but just internalize that fact. Again, barring some major scientific breakthrough, if your genes are your genes, Amor fati, love your fate. This is your fate is to be bald. And I understand if you want to try to keep your hair through your 20s and 30s, again, if you're single, and you know you're trying to find a partner, and you're emotionally attached to it. But this is something I went through. Surprisingly, I had thick hair all my entire life up until my mid 40s, and then in my mid 40s, it was just like it was gone. And so, you know, I could be the guy with the bald spot with a comb over at age 45, or I could get the razor out and shave my head. And so I opted to shave my head. And I looked into other options, including, you know, I looked at transplants and weighed the pros and cons of these different medications. And I said, you know what? I don't care. I already knew what I looked like bald being in the military. I had my head shaved for decades on a number of different occasions, especially on deployments, because you just don't want to deal with it. But, you know, hair loss is tough. I get it. So I completely understand if you want to use these medications to hold off, to stave off your hair loss, to slow it down. That's up to you. It's a personal decision. There's no judgment from me. I have prescribed these medications for just for that indication, but I always do it after having a really thorough discussion with the patient regarding the risks, benefits, and alternatives. And we do talk about post-finasteride syndrome because it's something that I don't want to be responsible for giving that to somebody and having all the devastating or potentially devastating sequelae of that condition. But I get it. If you want to use these drugs, it's entirely up to you. And I appreciate Dave and Kyle, saying that in their talk, because this ultimately comes down to being it's a personal decision. This just real quick. These are some pictures of men who have used either finasteride or dutasteride for a year. And I put these up there just to kind of put into perspective these drugs. Now, these men, obviously, all of them have like very advanced alopecia, so they probably would have benefited in terms of their hair from starting much earlier. But as you can see, I don't know. This is just me personally. I'm not impressed with these results. I don't think that a year's worth of DHT manipulation and taking a drug that has the potential side effect profile of a 5-alpha reductase inhibitor is worth it for these guys who are starting basically with peach fuzz and then having just a little bit more peach fuzz a year later. Like all these guys, you're still a balding middle-aged man. You're just slightly less balding. And the fact of the matter is, as soon as they stop these drugs, data is pretty clear that hair loss will continue to accelerate, and they're going to lose all of this extra hair that they grew. So anyway, that's just want to give you an idea. These drugs are not, we need to put them all into perspective. And I think patients should look at these types of photos and so they have realistic expectations. And again, there's just not a lot of good options for hair loss, in my opinion. I'm not a hair loss expert, so I want to just say that out of the gate. But again, having gone through it myself and looking at the options, I just haven't been that impressed with treatment options. It does seem that if you're losing your hair and you want to use these drugs, you probably should get on them earlier rather than later. Once things have advanced quite a bit, it's going to be very difficult to get a significant amount of regrowth, no matter what you do, short of a transplant, of course. Okay, let's talk a little bit about DHT physiology. I'm not going to get too far into this. So DHT is quite a bit more potent in terms of its androgenic activity than testosterone. So its binding affinity to the androgen receptor is at least twice that of testosterone. This is the pathway, the sort of the typical pathway that from cholesterol that results in the production of dihydrotestosterone. As you can see here, we have testosterone, it goes to DHT. There's also this backdoor pathway, which I'm not really going to get into. This is mainly relevant, or it comes up a lot in castrate-resistant prostate cancer. because your body can still, even after men are either physically or chemically castrated for the treatment of metastatic prostate cancer, they can still produce DHT, and that can be an issue for them in terms of progression of their disease. And it goes through this backdoor pathway. So there's two different pathways you should know about. This diagram here is actually really important because it has relevance about what I want to talk about next, which is some of the pitfalls of measuring dihydrotestosterone. I don't measure DHT at all in my patients unless they request it. Some guys just want to know, and I'm like, okay, fine. You know, you're paying for the lab, so if you want to know what your serum DHT level is, it's fine with me. But DHT is a intracrine and paracrine hormone. Okay, and that means that it's produced inside tissues locally, and it's used by tissues in which it's produced and in the local area. And so serum levels of DHT do not necessarily reflect tissue levels, which is where the hormone is active. So you're measuring one thing, but it doesn't always correlate with what you're seeing clinically or what you might be experiencing at the tissue level. So real briefly, this is how it works. So testosterone crosses, this is the most important part, it crosses into the intracellular space. Okay, and that's where 5-alpha reductase acts in order to convert it into DHT. The androgen receptor comes along. It's got these little heat shock proteins on it. So those are ejected, and then the DHT binds quite tightly to the androgen receptor. Two androgen receptors get together, so they dimerize, and then they go into the nucleus. They bind to DNA. They promote all these transcription factors, and that's how you get your clinical effect or your biological response. But I show this to you because it's important, again, important to realize the DHT is created inside the cell. So what you're measuring in the blood is just what leaks out of the cell. It's not what's used internally, and it's not a major contributor to the biological effects of DHT. Those happen inside the cell. And I'm going to show you some data to support that. So this is not like, you know, measuring certain other hormones and testosterone, thyroid, et cetera. This is these are hormones that act locally at the tissue level. Okay, this is a pretty cool paper that really eloquently shows this point. In this particular paper, they didn't just look at DHT, but a whole host of other sex steroids. So this is from the journal Endocrinology. It's from 2022, so it's fairly recent. Comprehensive sex steroid profiling in multiple tissues reveals novel insights into sex steroid distribution in male mice. So again, we have another mouse study here. Nothing wrong with that. It may not apply to humans. We do know that obviously there's going to be some differences between serum levels and intraprostatic levels in humans because we have we have prostate biopsy tissue studies that reveal that. It's a really interesting study because it shows that there are multiple hormones, not just DHT, that serum levels don't adequately reflect what's actually going on in the tissue. So this is a chart right here from the study, and I just highlighted the DHT portion of it, and it shows the correlation between tissues when the serum levels. So you can see these numbers here. So liver 0.76. So that means there's a 76% correlation essentially with the serum level and the level inside the liver cells themselves. So 1.0, if you had a correlation of 1.0, then whatever's in the serum would be exactly what's in the tissues. And notice that you don't see that in any of these tissues whatsoever. So they looked at liver, brain, bone, muscle, and then WAT. This is white adipose tissue, left atrium, prostate, seminal vesicles, adrenal glands, and testicles. And what you see here is that the strongest correlation between serum levels and tissue levels was in the brain and in the liver. But in the bone, way off, 0.41. In the muscle, it doesn't hardly correlate at all. In white adipose tissue, not so good. In the heart, not so much. The prostate is close at 0.77. And keep in mind, this is in rats. But in general, these serum levels, like there's nothing in here above 0.9, okay, which would be a really close correlation. So none of these tissues have a close correlation with the serum in terms of their DHT levels. So again, when you're measuring, you go and get your blood drawn, you want your doctor to get, oh, he didn't get a DHT level on me. Well, there's a reason he didn't get a DHT level on you. It's that it's kind of clinically useless, in my opinion. And you can argue maybe there's a couple use cases here and there, but the fact of the matter is that when you're even when you're on testosterone therapy, so the serum levels, they don't correlate with the amount of DHT in the prostate. They don't correlate with the amount in the heart. They don't correlate with what's in the muscle. So what are you testing? Like it's just kind of a ballpark number. And there's very loose association between tissue levels and serum levels. And so again, I was always trained that if you're going to order a blood test, it should be something called a decision node, right? Whether I'm ordering a troponin or a BNP or whatever the case may be in the emergency department. And the same thing when I'm ordering a hormone level. A decision node means I'm going to do something based on the outcome of that test. So the outcome of that test is going to change my management somehow. It's very difficult to do that with a serum DHT. You know, again, somebody out there can probably come up with a case for it, but it's challenging, and that's why I don't routinely check it. Again, unless a patient requests it. Now, to go along with that, here's another really interesting paper. It's 2014 assessment of the usefulness of dihydrotestosterone in the diagnostics of patients with androgenic alopecia. So I've had patients say, I want to check my DHT level because I want to see if I'm going to lose my hair. Okay, it seems like on the surface, it seems like a reasonable request. Well, here's a quote from this particular study where they took 49 individuals, 9 men, 19 women with androgenic alopecia, and then they had a control group, of course. So what did they find? All in all, increased serum concentrations of DHT were observed in both patients with androgenic alopecia and in those without. More importantly, the differences in mean values of DHT were not significant, according to two groups, and increased serum concentrations of DHT were not correlated with more severe hair loss. So DHT is involved in the pathogenesis of hair loss, but you can't predict how severe it is based off of serum levels. So this is a genetic condition largely. So, and I'll cut and paste it here. This is a quote. It says, the usefulness of serum DHT level measurements in the diagnosis of androgenic alopecia is questionable, especially in women. They found it was like totally not related in women. In the pathogenesis of androgenic alopecia, the most important factor seems to be the individual genetically based sensitivity of hair follicles to DHT concentration and their varied response to androgen action, right? So it's your genes. Here's another quote. It says, DHT is principally a paracrine hormone, as I mentioned. Circulating DHT concentrations have little relationship to prostatic and skin DHT concentrations. And here's another, this is a really important point, guys. In addition, within a broad range of serum testosterone concentrations, raising or lowering serum testosterone concentrations has little effect on prostatic DHT concentrations, skin as well. Okay, so that includes being on TRT. So if you're on TRT, the amount of DHT that's in your skin or in your prostate, it doesn't really change that much. There's a rate limit to that. So you will, as testosterone levels go up, you'll eventually saturate the enzyme, and of course you will stop. You're not going to make any more DHT after that. Okay, it just stops. It's the same with estradiol. So again, another reason really that, I mean, it just doesn't make a lot of sense to be routinely checking DHT levels, in my opinion, based off of this. Okay, let's switch gears a little bit and talk about left ventricular hypertrophy and whether or not there's any sort of connection with DHT and whether 5-alpha reductase inhibitors have any role in treating this condition. I think Kyle might have brought this up in the video. Just this is one of those things that I think just kind of was sort of said in passing, and I would have loved for them to go into it in more detail. And maybe there'll be a part 2 where they talk about this a little bit more. But this is something I see, I mean, almost on a daily basis. LVH is incredibly common in the population, especially as people get older. And in fact, last night I was working late in the emergency department and had a guy who actually wasn't that old. I think he was in his late 40s or early 50s that came in with something called PRES syndrome. It's posterior reversible encephalopathy syndrome. It's a disorder of elevated blood pressure causing a variety of different neurological effects. And he had a blood pressure of 260 over 130 when he came in. And looking at his EKG, it looked like this. So this is sort of a classic finding of left ventricular hypertrophy on an EKG. It can look a little different in certain people, but you see some very high voltage here across the anterior leads. We have something called a strain pattern, and this is sort of pathognomonic for LVH, which, by the way, is something that, you know, the initial screening for LVH, if you're worried about it, is an EKG. Now, EKGs are not terribly sensitive for this, but it's a good starting place. You certainly can have significant LVH and not have it show up on an EKG, but you certainly, again, this is the first way to at least be evaluated for this. And then ultimately, if there's concern, then you go ahead and get an echo. So the guy, last night, I went into the room with the resident. We had our ultrasound machine, and we did a bedside echo on him. And he had an incredibly thick ventricle, incredibly compromised filling space there. The septum was really thick, looked like a big piece of thick tri-tip. And this is from long-standing, likely many, many years of untreated hypertension, which is the most common cause of LVH. This is a little diagram here showing a normal heart and then LVH. So you have the little arrows here, thickened ventricular septum. This is actually what this guy's heart looked like. So you can see the chamber, the amount of space, the amount of volume in there when the heart relaxes in diastole. So it's called the end diastolic volume. When the walls are really thick like that, there's less blood in there. So the less blood that's in the ventricle at the end of diastole there's less blood being pumped out forward. So you get a drop potentially in cardiac output. You can see in the normal heart here, this area in the left ventricle, there's a lot more space, a lot more volume there. So per beat, this person on the left is going to have more forward flow, better cardiac output than the one on the right. So what causes LVH? Far and away the most common thing, here's a list: essential hypertension, renal artery stenosis, which leads to hypertension. Now you can get a little bit of LVH, which is in a normal athlete. It's called an athlete's heart. It's not pathological. It's just a response to intense exercise and being being a fit individual. So that's not abnormal necessarily. In addition to hypertension, probably the most common thing that I see is critical or more severe aortic stenosis, which is a tightening of the aortic valve. So as the diameter narrows as you get older, the valve oftentimes becomes calcified. And so the heart has to squeeze harder to push that blood through a smaller diameter. It has to work and work and work. And so there's a hypertrophic response to that. So other valvular problems, aortic regurgitation, et cetera, et cetera. I'm not going to get into all of those, but it's extremely common. I see it all the time. It's almost always related to what they call basically pressure overload. And that's what you'll see in all the studies in rats and the studies where they actually use 5-alpha reductase inhibitors is they induce pressure overload first. So they usually like tie off the aorta to create a high pressure system, and then the ventricle has to work and work and work, and then it starts to get thicker and thicker and thicker. So the connection with DHT is a little, I wouldn't say it's tenuous. There is an association with higher DHT levels and the development of hypertrophic cardiomyopathy, but at the same time, there's also a very strong association with high DHT levels and pressure overload, mainly from hypertension. So is it the DHT? Is it the hypertension? Is it a combination of both? So these are unanswered questions in this area. So let's talk about some of the studies here. So this is one that people who suggest that we use DHT to treat LVH, they kind of point this one out. I've seen this one talked about in the past. It's from Scientific Reports, 2018. Anti-androgenic therapy with finasteride in patients with chronic heart failure, retrospective propensity score-based analysis. So they took a bunch of people with heart failure that have left ventricular hypertrophy. So this is likely heart failure with preserved ejection fraction. And then noted that some of them were on 5-alpha reductase inhibitors, specifically finasteride. And then they looked and they did echocardiograms on them over the years to see what the effect was. Like, could we regress some of this left ventricular hypertrophy if we used DHT? And their conclusion was that yes, in fact, we could. But when you dive into the actual numbers, you're going to find this is not super impressive, at least in my opinion. So here's a chart here where they look at this, and they did a bunch of different measurements here. Now, the most important thing ultimately when you're trying to treat LVH and heart failure is the ejection fraction. It's the amount of blood that actually is pumped out of the heart. It's one of the major goals of therapy generally is to improve the ejection fraction. So the more forward flow, the better you perfuse your organs. And in this study, you can look at it here. You can look at the control and the treatment groups, whether it's an unmatched cohort or a matched cohort. There's no significant difference here in ejection fraction. So it didn't make a big difference when it came to improving the ejection fraction. The one thing that actually really matters in heart failure patients, we didn't see that finasteride made a whole lot of difference in that area. So the only area it actually made a statistically significant difference is in the thickness of the intraventricular septum. So that's the piece of the heart that's in between the right and the left ventricle, that middle area that I showed you guys earlier on the diagram. But again, this is a great example. They say that it made a significant difference. Well, that means it's statistically significant. It doesn't mean that it's clinically significant. So the ejection fraction didn't change. And when you look at these numbers, so on average, it went from 13.3 millimeters to 12.6 millimeters. So a small change, 0.7. So maybe that's significant, maybe it's not in terms of clinical significance. The fact that the ejection fraction didn't change statistically or appreciably in any way means that this is, to me, that this is not clinically significant. All these other measurements, the end diastolic diameter, all these other measurements of the left atrium, none of these were statistically different between the finasteride and the non-finasteride users. But because there was a statistical difference in the intraventricular septum, they said, okay, this is finasteride is effective at treating LVH. Well, I don't know. I think that's up for debate. What it does do is it poses a very interesting question, and it just means we need more studies. We need randomized controlled studies with not just a few patients, but we need like hundreds, and maybe it'd be nice to have a couple thousand with documented LVH, and then put them on these drugs, and then see what sort of a difference it makes over time. And even better, it would be great to have a bunch of bodybuilders using high doses of androgens, putting them on finasteride and seeing if there's any difference in the rate of LVH over time. The reality is we're never going to get those studies. So it's a far cry to point to these rat and small human studies that have questionable results in patients with established LVH. It's a far cry to say we should be using this in men on TRT or even bodybuilders to prevent the development of left ventricular hypertrophy. That's not supported by the literature. Maybe it's true, maybe it's not. We just need more studies on it. So if you want to prevent yourself from getting left ventricular hypertrophy, you need to go back and look at what are the major causes of left ventricular hypertrophy? It's pressure overload, right? So the low-hanging fruit is obviously treatment of hypertension. Do not allow yourself to become hypertensive. And if you are hypertensive, you need to address it through diet, lifestyle, weight loss, use of a CPAP if you have sleep apnea, and in many cases, you're going to need medications. So I think, the better approach, again, if you have LVH, or if you're concerned about developing LVH on testosterone therapy, one is don't abuse androgens, okay? Just use an appropriate amount of testosterone in order to optimize your health, and don't go beyond that. If you do go beyond that, then I think we have very good data on a number of other drugs that we know will treat LVH, and we know have good efficacy. Things like ACE inhibitors, angiotensin receptor blockers. Obviously, telmisartan is the one everybody talks about, but this is a class effect, so all of them have benefit when it comes to LVH and heart failure. SGLT2 drugs, okay, those are did a video on that. Well known now within the last couple of years to be effective at preventing abnormal cardiac remodeling. And so if you want to use a 5-alpha reductase inhibitor, I mean, be my guest. It's just that's, in my opinion, like way down on the list of things that you could consider using if you have LVH, or if you're just a regular guy on TRT and you're worried about getting LVH. That would not be the first drug I would go to, the first class of drugs, like not by a long shot. That's like 4 or 5 down the road. It's address the things that cause LVH, which again, most guys is going to be pressure overload, which translates largely into hypertension. Make sure that that's addressed, sleep apnea, etc. And then an ACE or an ARB, an SGLT2 drug, or even a beta blocker. Obviously, beta blockers have been around forever. They have very well documented benefits in morbidity and mortality in patients with heart failure. That's going back like over 20 years. And only at the end of all of that, if you want to try finasteride or dutasteride, you could do that. But it's just the literature support is very soft in that department. And so it was mentioned in passing in this video. I think it was stated a little bit more definitively than the data would warrant, just in my opinion. So a conversation to have with your doctor if that's something you're concerned about. And then I just want to briefly touch on the hematocrit and the psychological issues that were mentioned in the talk. This is an unanswered question. Clearly, like DHT it's pretty clearly associated with the production of red blood cells, with erythrocytosis. What we don't have is good randomized controlled trials in men on testosterone replacement therapy using finasteride or dutasteride and documenting what the changes in hematocrit, if any, are. There are case studies which seem to show that there's an effect in some cases, but no big studies on this. Again, I kind of doubt that we'll ever have them just because there's just no financial incentive for either the government or for drug companies to sponsor studies like this. So if that's something that you want to entertain, by all means, have that conversation with your doctor and understand the risks, benefits, and alternatives, as I mentioned earlier, and certainly you can proceed with it. But I don't recommend it, only because I don't have any data really to support that that's going to make any kind of meaningful difference. And quite frankly, as I've talked about before, I don't concern myself too much with the typical erythrocytosis that we see in men and TRT and the typical ranges that we see. I think the data so far suggests rather strongly that this is not really an issue. But maybe it's an issue for you as an individual. Everybody's a little bit different. And so, maybe something you could consider. There's just, again, it's uncharted territory, right? Like a lot of the stuff in the men's health world, as I mentioned earlier, there are things that sort of make sense physiologically. You're welcome to try them. I'm certainly not opposed to, you do what you want with your body, but it's, I think if anybody, a physician, provider, guy on an internet forum tells you, yeah, absolutely, man, Proscar is going to drop your hematocrit, well, prove it, prove it to me. Show me the studies that that's the case. And there just aren't any right now. So it might be true, but there's not a lot of studies. So I like data. I'd like to see those studies before I recommend it routinely for my patients. Now, the psychiatric effects, I'm glad that they brought this up because, neurosteroids are incredibly important. This is personally one of the reasons why I don't like monkeying around with estradiol and dihydrotestosterone, is because there are often unforeseen psychiatric effects and mood effects and other neurological issues that can arise. And there's no way to really predict who's going to have these and who isn't. So it's something that you have to worry about. So I think what they said was actually pretty reasonable. But here's the thing. Again, it gets back to evidence. So there's if you're just the average guy on TRT, or let's say you're the average guy on TRT, but you suffer from PTSD, maybe you have bipolar disorder, anxiety, or schizophreniform, or some other psychiatric condition, there's no evidence whatsoever that the prophylactic use of a 5-alpha reductase inhibitor will prevent any sort of adverse psychiatric outcome in your particular case. There's lots of case studies. There's almost no data to support that. So again, talk to your doctor about it. This is an individualized thing. You've got to have that conversation with your doctor. And if you decide to move forward with it, it's totally fine, obviously, but you just need to understand that you're not, this is not this is not evidence-based medicine per se. So again, in my opinion, a history of a mental health disorder like the ones I mentioned, that's not an indication to use a 5-alpha reductase inhibitor, unless you and your doctor decide that that's worth pursuing. But I personally don't do that. What we do know is that there is a certain rate of adverse psychiatric effects with these drugs in some people. This is a study here from the Australasian Journal of Dermatology. It's fairly fresh, just from August 2024. And what they talk about here is that there's, in general, a relatively low rate of adverse psychiatric events in patients that take these drugs. They say about 2.3%, which I think seems reasonable. It's actually quite similar, they found, to placebo. Maybe that's true, maybe it's not. They do quote higher rates of anxiety in 5-alpha reductase users, which may or may not be related to use of the drug, but in general, for most people, adverse psychiatric events are rare. Again, they're not looking at a population of people exclusively with PTSD. They're not looking at rates of adverse effects in people with bipolar disorder or mania. To my knowledge, those studies don't exist. So again, it's uncharted territory. You're going to be manipulating neurosteroids in a way that can be unpredictable in somebody who has potentially underlying serious psychiatric disease, and that seems a bit risky to me. That's just my personal opinion. It's something that it has to be done with a lot of thought. And then finally, I just want to talk briefly about post-finasteride syndrome. I've got another video on that. There's a bunch of excellent ones on post-finasteride syndrome that are on the channel I mentioned, and I think you guys should watch those. This is a pretty good article if you're interested. It's from the Neurobiology of Stress, Post-Finasteride Syndrome, an Emerging Clinical Problem from 2020, and it goes into great detail in terms of what post-finasteride syndrome is, and what some of the potential underlying mechanisms are. This is a condition that we still to this day we don't have a really good handle on. We don't have a good handle on what causes it. We don't have a good handle on how to treat it. There's a lot of opinions, let's put it this way. And I'm hoping that we'll have a lot more clarity here in the next few years. But the fact is that PFS the symptoms can range from fairly mild, depression, low libido, erectile dysfunction on one end of this continuum, into just completely life destroying neuropsychiatric disease on the other, up to and including the point where men commit suicide. So this is a diagram here showing some of the very wide-ranging symptoms that can happen in men who use 5-alpha reductase inhibitors and suffer from PFS. So there's reproductive issues, so erectile dysfunction, penile shrinkage in some cases, issues with peripheral circulation in the brain. So they talk about altered levels of neuroactive steroids in the hippocampus and the cerebellum, decreased neurogenesis, alterations in the gut flora. There can be renal issues, which I was not aware of before. That's kind of interesting. And then obviously behavioral issues, depression, anxiety, etc. So it's a wide-ranging condition. It's not to be taken lightly. And quite frankly, the rate at which this happens is unknown, because obviously there's going to be a number of cases that just go unreported or unrecognized every year. It's somewhere between 1% and 5% is what I've read, but nobody knows for sure. Dave mentioned in the video that the company that creates finasteride actually went out of their way to suppress some of the data in this regard. And so we don't really know what the risk is for any given individual. So you have to just take that into account. Now, the fact of the matter is, most men, the vast majority of men that use these drugs, they do okay. So they don't have these adverse side effects, but it's very difficult to predict who's going to have them and who isn't. It'd be great if we could, because then we could steer certain men away from these drugs and make them available for men who are perhaps at lower risk. But we just don't know. We just don't know. So again, it is a bit of a game of Russian roulette when you take these drugs. So this comes down to personal values. Majority of the time, men are using this for cosmetic reasons, and I certainly don't have a problem with that. I think it's probably safer to use the topical versions of this. You get less systemic absorption, but you still get a nice clinical effect. But again, that's up to you and your doctor how you want to do that. Now, if you're using these drugs prophylactically to prevent other conditions, left ventricular hypertrophy, elevations in hematocrit, prostate issues, the data is not as definitive as we would like it to be. And you're not in an evidence-based environment when you proceed down that road, in my opinion. So I'm not saying don't do it. Just have a conversation with your doctor about it so that you know what you're getting into and you know what you're risking. And just keep in mind that we just don't know. There's a lot we don't know about these drugs. I hope we will know more in the future, but as it stands right now, we just don't really know. So guys, that's all I have for you today. I'm glad to be back making videos for you. I will do my best to keep these coming now that I'm starting to settle in. As you can see, I'm in a new office. I've got nothing on the walls yet, but I'll start putting things together here over the next couple of weeks. When in the few spare hours that I have off, I'll be doing a lot of reorganizing and decorating around here. So let me know if you have any questions. If you have experience with these drugs, positive, negative, anything else in between, I always love to hear from you guys. And please leave those in the comments. I will catch you next time. Bye-bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.